How does a patient consume 0 ounces of liquor, yet walk into a clinic on an otherwise unremarkable afternoon with a staggering gait and a blood alcohol concentration of 0.3? The physical signs of severe intoxication are undeniable, from the slurred speech to the heavy, swaying steps, even though the individual has not encountered a single drop of alcohol in a decade. These 2 clinical case studies trace the unexpected vulnerabilities of the human nervous and metabolic systems, moving from a presentation of spontaneous, entirely internal intoxication to a patient whose muscles paralyze completely at the onset of a simple smile. There is no obligation to stay awake for the final medical verdicts. You can follow the diagnostic process for as long as it holds your interest, knowing it is perfectly fine to let the narrative fade and drift into sleep at any time. The clinical observations will proceed quietly. The pacing will stay slow, and nothing here will startle you. The drunk who never drank. The patient was brought into the clinical setting on an otherwise unremarkable afternoon, presenting a picture that the medical staff had seen countless times before. The individual moved with a heavy, swaying gait, requiring guidance just to navigate the hallway. Their speech was slow and thickly slurred, syllables running together into a soft, unintelligible murmur. To the patient, the experience was described as moving through a dense, invisible fluid, a profound mental fog that settled over their mind without warning. They felt an overwhelming exhaustion, a clumsiness that made simple tasks like holding a cup or buttoning a shirt feel like navigating a complex puzzle. Hanging around the patient, unmistakable and sharp, was the scent of alcohol. It was not a subtle hint, but the heavy, sweet and sour odor of a long, sustained drinking episode. The intake nurses documented the presentation with practiced efficiency, noting the lack of coordination, the bloodshot eyes, and the delayed responses to simple questions. The patient had been enduring these episodes of sudden, debilitating impairment for many months. The spells would arrive seemingly out of nowhere, bringing deep confusion and resulting in lost jobs, strained relationships, and recently, a serious legal charge for driving under the influence. When the attending physician began the physical examination, the findings continued to build a consistent, familiar narrative. The doctor worked quietly and thoroughly, starting with the eyes. A faint but definite yellowing was visible in the whites, a condition known as jaundice. This happens when the liver is too damaged or overworked to filter out bilirubin, a yellowish waste product created when old red blood cells are broken down. Moving to the chest, the doctor noted several spider angiomas. These are tiny, branching blood vessels that appear just beneath the surface of the skin, resembling a delicate red web. They are a classic indicator that the liver is struggling to process estrogen, causing the superficial blood vessels to dilate. When the physician gently pressed on the right side of the abdomen, just beneath the rib cage, the liver felt firm, swollen, and tender. The laboratory results painted an even clearer picture. Blood tests revealed a significant spike in liver enzymes, the proteins that help the organ do its job. When liver cells are damaged, they spill these enzymes into the bloodstream. The tests showed a very specific pattern. One enzyme, known as AST, was elevated to more than twice the level of another enzyme, ALT. In the medical world, this particular ratio is a strong, reliable signature of alcohol-induced liver damage. On top of this, the toxicology report showed a blood alcohol concentration that was staggeringly high, well over the threshold for legal intoxication, representing an amount of alcohol that would leave anyone severely impaired. Based on the evidence, the medical team arrived at the obvious and most responsible diagnosis. The patient was suffering from late-stage alcohol use disorder, complicated by alcoholic hepatitis, which is severe inflammation of the liver. It was a textbook case. Every symptom, every physical sign, and every laboratory value pointed in exactly the same direction. When the doctors gently discussed this with the patient, outlining the need for immediate intervention and a cessation of drinking, the patient became quietly desperate, swearing that they had not consumed a single drop of alcohol in years. The medical staff met this denial with calm professionalism. They were not surprised, nor were they angry. Denial is a deeply woven part of addiction. It is a protective psychological mechanism, often so strong that patients facing severe medical and legal ruin will maintain their innocence, sometimes genuinely believing their own version of events, despite the physical reality of their failing bodies. The doctors simply noted the denial in the chart and moved forward with the standard protocol for alcohol withdrawal and liver support, confident in the science in front of them. To ensure the patient remained safe during the expected withdrawal period, they were admitted to a strictly monitored observation room. The environment was entirely controlled. There were no visitors allowed, no personal belongings, and no possible access to alcohol. The nursing staff checked the room thoroughly and brought only standard hospital meals and water. Several hours into this supervised isolation, the patient ate a warm lunch of pasta and a roll of bread. A short time later, the patient's speech became noticeably thicker, and their coordination declined further. A routine follow-up blood draw was taken to monitor their clearing system. When the results returned from the laboratory, They showed that the amount of alcohol in the patient's blood, which should have been steadily falling in the empty room, had instead gone up. The blood test result was, according to the rules of a controlled environment, an impossibility. The hospital staff initially assumed a simple laboratory error, perhaps a mix-up of vials or a miscalibrated machine. Blood was drawn a second time, and the result returned identical to the first. The concentration of alcohol in the bloodstream had measurably increased since the patient first entered the room. Since the patient had been under continuous observation, the medical team had to confront a confusing physical reality. The patient had genuinely not consumed any alcohol. The only things that had passed their lips in the last several hours were water, a plate of cooked pasta, and a plain roll of bread. The physicians began to consider the fundamental mechanics of human digestion, tracing the path of that unremarkable meal to understand how it could possibly result in a rising blood alcohol level. To understand the puzzle facing the medical team, it is helpful to follow the quiet journey of carbohydrates through the human body. When a person eats a meal heavy in starches, such as pasta and bread, the digestive process begins immediately in the mouth. As the food is chewed, saliva mixes with it, introducing special proteins called enzymes. These enzymes act like microscopic scissors, beginning the work of snipping the long, complicated chains of plant starch into smaller, simpler pieces. This softened mixture then travels down the esophagus and into the stomach, where it is bathed in strong acids that further break apart the food. However, the true work of extracting energy from a meal happens just past the stomach, in the winding channels of the small intestine. By the time the pasta and bread reach this area, the long chains of carbohydrates have been systematically dismantled into their most basic building blocks. For starchy foods, this primary building block is a simple sugar called glucose. In a standard, healthy digestive system, the walls of the small intestine are lined with millions of tiny, finger-like projections. These delicate structures are specifically designed to catch the passing glucose and ferry it across the barrier of the intestinal wall, depositing it safely into the bloodstream. Once in the blood, this simple sugar is carried throughout the body to be used as fuel by almost every tissue, from the contracting muscles of the heart to the firing neurons of the brain. The human body burns this glucose cleanly, using oxygen to convert the sugar into usable energy, water, and carbon dioxide gas that is eventually exhaled. At no point in this normal, everyday human digestive process is alcohol created. The system is designed only to harvest simple sugars and burn them for power. Yet human digestion does not happen in a sterile vacuum. The human gut is not merely a tube acting as a chemical processing plant. It is a vast, thriving habitat. The intestines are home to trillions of microscopic organisms, primarily bacteria, along with a much smaller population of fungi. This invisible community exists in a delicate, highly competitive ecological balance. The bacteria usually dominate this space, coating the intestinal walls and consuming leftover nutrients the human body does not absorb. They perform vital maintenance, producing vitamins and occupying available physical space so that less helpful organisms cannot take root. The medical team, reviewing the patient's wider medical history, began to look for events that might have disturbed this internal ecosystem. Often, such a disruption occurs following a course of strong antibiotics, or perhaps a severe intestinal illness. Antibacterial medications are designed to clear out harmful infections, but they cannot easily distinguish between the bacteria causing a sickness and the helpful bacteria living peacefully in the gut. When a broad-spectrum antibiotic sweeps through the digestive tract, it can wipe out large portions of the normal, beneficial bacterial population, leaving vast stretches of the intestinal lining uninhabited. This sudden loss of bacteria changes the environment of the gut entirely. The fierce competition for food and space is removed. For the fungi that naturally reside in the digestive tract in very small, suppressed numbers, this presents an unprecedented opportunity. Fungi, such as various microscopic yeasts, are built differently than bacteria. They belong to a completely different branch of biology, which means that standard antibacterial medications do not harm them at all. Left alone in a newly emptied landscape, and provided with a warm, dark, and nutrient-rich environment, these yeast colonies can begin to grow and multiply rapidly. When yeast populations expand to abnormally high levels in the small intestine, they intercept the nutrients intended for the human body. The meal of pasta and bread, having been efficiently broken down into simple glucose sugars by the human digestive enzymes, arrives in the small intestine right, where these enlarged yeast colonies are waiting. The yeast absorbs the sugar, but it does not process it the way human cells do. It relies on a different method to extract energy from its food, particularly in a crowded, low-oxygen environment like the interior of the human gut. This alternative process is known as fermentation. Instead of burning the glucose cleanly with oxygen, the yeast chemically splits the sugar molecules apart. This particular method of generating cellular energy leaves behind two distinct waste products. The first is carbon dioxide gas, which can cause significant abdominal bloating and discomfort. The second waste product is pure ethanol, Ethanol is the exact chemical compound that makes up the intoxicating alcohol found in beer, wine, and spirits. As the yeast rapidly consumes the flood of glucose from the patient's meal, it continuously excretes this pure ethanol directly into the surrounding fluids of the small intestine. The body is completely unaware of the source of this chemical. The delicate lining of the intestine is designed to absorb liquids and nutrients, and it readily absorbs the ethanol directly into the surrounding blood vessels. Once in the bloodstream, it follows the standard anatomical route. Blood from the digestive tract drains into a large vessel called the portal vein, functioning as a direct highway to the liver. The liver is the body's primary filtration plant, tasked with detoxifying harmful substances. When the alcohol arrives via the portal vein, the liver begins to process it, working steadily to break it down before it can reach the rest of the body. However, the sheer volume of an overgrown yeast colony fermenting a heavy carbohydrate meal can produce a staggering amount of alcohol. The liver processes alcohol at a steady, fixed rate, much like a drain emptying a sink. If the flow of alcohol coming from the gut is faster than the liver's enzymes can clear it, the alcohol inevitably overflows into the general circulation. From there, the heart pumps the alcohol to the brain and every other organ. This is precisely what happens when someone drinks heavily. But for this patient, the source of intoxication was entirely internal. Their liver had been subjected to this hidden deluge for an extended period, explaining the severe damage that originally prompted their medical crisis. Every time the patient ate a typical meal containing carbohydrates, whether it was a bowl of rice or the hospital's pasta and bread, they were unwittingly feeding the overgrown yeast. The fungal colonies dutifully converted these innocuous foods into strong alcohol. The patient would then absorb it, becoming genuinely intoxicated without ever lifting a glass. It was a cycle of chronic, involuntary poisoning that perfectly mimicked severe alcohol abuse. As the doctors in the observation room slowly pieced this mechanical reality together, they realized the patient had told the truth all along. They had not been drinking in secret, nor were they suffering from profound psychiatric denial. Their own digestive system had been quietly operating as an internal brewery, fermenting their meals and taxing their liver from the inside out. Understanding this hidden physiology changed the entire approach to the situation. The medical team's focus shifted away from managing an assumed behavioral addiction and toward the clearer task of correcting the microscopic imbalance that had taken over the patient's digestive tract. The medical team finally had a name for this rare and deeply misunderstood condition. It is known as autobrewery syndrome, or sometimes gut fermentation syndrome to definitively prove the diagnosis and identify the exact nature of the fungal overgrowth. The doctors conducted a careful, supervised test. They administered a measured amount of pure glucose, a simple sugar, while the patient remained under constant observation in a controlled hospital room. For hours, they monitored the patient's blood. Just as the theory predicted, the blood alcohol levels began to rise steadily, despite the patient having nothing to drink but water and the sugar solution. This controlled test was the final piece of evidence, transforming a highly unusual hypothesis into a documented medical certainty. To understand exactly what was living in the digestive tract, the team took fluid samples from the patient's stomach and small intestine. When these samples were placed in a laboratory dish and kept warm, colonies of yeast began to flourish. The laboratory identified the primary culprit as a strain of yeast very similar to the ones used in commercial baking and brewing. At some point in the past, perhaps after a course of antibiotics that had cleared out the helpful bacteria normally guarding the intestine, this ordinary yeast had found an empty environment and settled in. Over time, it had multiplied, turning a typical digestive system into an active fermentation vessel. With the mechanics of the illness fully mapped out, the doctors could finally offer a treatment plan. The approach was methodical, designed to dismantle the internal brewery piece by piece. The first step was to change the patient's diet completely. Because yeast relies on carbohydrates and sugars for fuel, the medical team prescribed a strict, low-carbohydrate regimen. All breads, pastas, rice, and sugary foods were removed from the patient's meals. By replacing these with proteins and vegetables, the doctors effectively starved the yeast colonies, cutting off the raw materials they needed to produce alcohol. The second step involved clearing the overgrowth directly. The doctors prescribed a specialized antifungal medication. Unlike antibiotics, which target bacteria, antifungals are designed to seek out and break down the tough cell walls of fungi and yeasts. The patient took this medication for several weeks. It worked its way through the digestive system, slowly dismantling the stubborn fungal colonies that had taken root in the intestinal lining. As the yeast died off, the production of internal alcohol ground to a halt. The final phase of the treatment was focused on restoration. The patient's digestive tract was now a fairly empty landscape, and the doctors needed to ensure that healthy organisms returned before the yeast could ever make a comeback. They introduced a steady regimen of probiotics, which are concentrated doses of the beneficial bacteria that normally inhabit a healthy human gut. These helpful microbes act like a protective forest, taking up space and resources so that invasive weeds, like the brewing yeast, cannot find room to grow. The recovery was gradual but profound. Without the constant, involuntary influx of alcohol, the patient's liver was finally given the opportunity to rest and repair itself. The liver is a remarkably resilient organ, capable of regenerating its tissues when the source of damage is removed. Over the following months, the routine blood tests that had once shown alarming signs of organ failure began to normalize. The physical healing was accompanied by an equally significant mental clearing. The persistent brain fog, the fatigue, and the unsteadiness that had plagued the patient for years slowly faded away, replaced by a steady, reliable clarity. Perhaps just as important as the physical recovery was the restoration of the patient's life and reputation. Armed with extensive medical documentation, the patient was able to prove that their past legal and social troubles were the result of a rare physiological illness, not a behavioral failing. The driving charges were reevaluated in the light of this new medical evidence, and the heavy strain on the patient's personal relationships began to ease. Family members and friends who had struggled to understand the apparent deception now understood that the patient had been fighting an invisible illness all along. The patient experienced the profound relief of finally being believed, moving forward with their health and their integrity intact. This unusual sequence of events offers a humbling perspective on the nature of medical diagnosis. Human biology is vast and endlessly complex, yet medical practice must often rely on recognizing common patterns to make sense of a chaotic world. When a person's suffering perfectly mimics a familiar pattern, it is almost a reflex to assume the standard explanation, sometimes at the cost of dismissing the patient's own voice. True diagnostic clarity requires a willingness to look past the statistically probable, maintaining the quiet realization that the body is entirely capable of breaking the rules we have written for it. The paralyzing smile. The patient arrived at the neurology clinic, moving with a slow, deliberate stiffness, leaning heavily on a wooden cane to safely cross the short distance from the waiting room. They were in their late 50s, and the trouble had begun over a year earlier as a mere whisper of an affliction. It started with a faint, persistent tingling in both feet, a sensation much like the static of a limb falling asleep, only it never woke up. Over the following months, the tingling slowly evolved into a profound numbness. The patient described the feeling as though they were constantly walking on a thick foam mattress, unable to sense the solid, reassuring ground beneath their shoes. Soon, their legs began to feel heavy and uncooperative, requiring a conscious, tiring effort to lift them with each step. They noticed they would stumble if they had to get up in the middle of the night. During the day, they relied on their eyes to watch their feet and the floor, compensating for the lack of feeling. In the dark, that visual anchor vanished, and their balance vanished with it. In the examination room, the neurologist worked quietly and methodically to map the extent of the damage. First, there was the reflex test. When the doctor tapped just below the kneecap with a soft rubber hammer, the leg jerked forward with an exaggerated, forceful kick. This is a crucial clue in neurology. Usually, the brain sends a continuous, calming signal down the spinal cord to keep our physical reflexes in check. When a limb reacts too strongly to a simple tap, it suggests that this calming signal from the brain is being interrupted somewhere along its journey down the spine. Next, the doctor pressed the base of a gently vibrating tuning fork against the patient's ankle bone. The patient could feel the cold metal resting on their skin, but they could not feel the vibration. The doctor then asked the patient to stand still, place their feet together, and simply close their eyes. Immediately, the patient began to sway and would have fallen if the doctor had not reached out to steady them. This phenomenon happens when a person loses proprioception, which is the brain's internal, automatic map of where the body is in space. Without the visual cues of the brightly lit room, the patient's brain simply had no way to know where their feet were. Taking all these physical signs together, the clinical picture pointed directly to a problem in the spinal cord, specifically in the long, vertical columns of nerves that carry sensory information up to the brain and motor commands down to the legs. The doctor diagnosed a progressive, untreatable degenerative spinal disease. This was a thoroughly reasonable and sound conclusion based on the evidence available in the room. The spinal cord is essentially a tightly bundled cable of electrical wires connecting the brain to the rest of the body. Each of these microscopic wires, or nerve fibers, is wrapped in a protective fatty coating, much like the rubber insulation on a household appliance cord. In certain degenerative diseases, this protective coating slowly wears away, and the nerve fibers themselves begin to wither and die. When the cables carrying signals from the feet degrade, the brain loses the sensation of vibration and position. When the cables carrying movement commands degrade, the legs become weak and rigid. The patient's symptoms marched perfectly in step with this classic pattern of gradual, unrelenting nerve decay. It appeared to be a tragic, but historically recognizable condition, one for which modern medicine had no cure, offering only physical therapy to help manage the steady decline. Before finalizing the chart, however, the neurologist reviewed the routine blood work that had been drawn a few days prior. Blood tests are a standard procedure in these cases, largely to rule out common infections or basic vitamin deficiencies. The results showed that the patient had plenty of vitamin B12, which is necessary for healthy nerves, further supporting the idea of an unpreventable degeneration. But further down the page, among the rows of normal numbers, there was a minor discrepancy. The patient's white blood cells, the cells responsible for fighting off infections, were unusually low. Alongside this, their red blood cells, which carry oxygen through the body, were slightly too large. It was a subtle, quiet abnormality in the blood, one that did not naturally belong in the story of a purely degenerative nerve disease. To make sense of this quiet discrepancy in the blood work, the neurologist had to look past the spinal cord and consider the bone marrow. Hidden within the hollow centers of the larger bones, the marrow acts as a continuous manufacturing plant, responsible for producing every red and white blood cell the body requires. When this factory is functioning normally, cells are assembled, matured, and released into circulation in a steady, highly regulated stream. The patient's test results suggested that this assembly line was struggling. The white blood cells were scarce, meaning they were likely dying off before they could fully mature. The red blood cells, meanwhile, were abnormally large. In the world of hematology, an oversized red blood cell often indicates a failure in cell division. The marrow creates the building blocks for a new cell, but lacks the final necessary ingredient to divide it in two, resulting in a single, swollen cell that functions poorly and takes up too much space. Typically, this specific pattern of manufacturing failure is caused by a shortage of vitamin B12. Vitamin B12 is essential for cell division, and its absence also happens to cause a slow, progressive decay of the nerves in the spinal cord. It is a neat, common explanation that perfectly ties together blood abnormalities and leg paralysis. But the patient had already been tested for a B12 deficiency, and their levels were entirely normal. The neurologist was left to search for something much rarer, something that perfectly mimicked a B12 deficiency without actually being one. This search led into the subtle, less frequently traveled pathways of human nutrition, eventually arriving at another essential nutrient, one needed in such microscopic amounts that it is often overlooked. The doctor ordered a test to measure the patient's copper levels. When we think of copper, we usually picture plumbing pipes, old coins, or electrical wire. We rarely think of it as a vital biological component. Yet, in the human body, this trace metal is an absolute necessity for life. It is not used in large quantities, but it sits at the very center of several crucial enzymes. Enzymes are the tiny biological machines that facilitate chemical reactions in our cells. You can think of them as specialized tools on an assembly line. Without copper to serve as the functional core of these tools, the machines simply stop working. In the bone marrow, a specific copper-dependent enzyme is required to properly incorporate iron into new red blood cells. Without it, the cells become trapped in their immature, swollen state. Another copper enzyme is needed for the survival of white blood cells. This perfectly explained the quiet abnormalities lurking in the patient's routine blood tests. But more importantly, copper's role extends far beyond the blood. It is fundamentally tied to the nervous system, which explained the gradual paralysis creeping up the patient's legs. The nerves in the spinal cord are essentially long, delicate biological cables carrying electrical impulses from the brain to the furthest reaches of the body. To ensure these signals travel quickly and do not leak out into the surrounding tissue, the nerve fibers are wrapped in a thick, fatty layer of protective insulation called myelin. This myelin sheath is not a static covering. It is living tissue that requires constant maintenance and repair. The specialized cells responsible for wrapping and tending to this insulation rely on a specific set of copper-dependent enzymes to generate the energy and materials they need. When the body runs out of copper, the cellular maintenance crew is essentially forced to halt their work. Over time, the myelin insulation slowly thins, frays, and breaks down. As the bare nerve fibers are exposed, the electrical signals descending from the brain begin to scatter and fade. By the time the faint signals finally reach the muscles of the legs, they are weak and disorganized, leading to the exact kind of heavy, rigid weakness the patient was experiencing. When the laboratory results returned, they confirmed the neurologist's suspicion. The patient's copper levels were so low they barely registered on the testing equipment. The profound nerve damage was not the result of an untreatable, spontaneous genetic decay. It was a severe, systemic starvation of a single trace metal. This answered one question, only to immediately raise another. How does an adult living in the modern world run out of copper? Copper is abundant in an ordinary diet. It is found in nuts, seeds, whole grains, beans, and chocolate. The patient ate a normal, varied diet and had a healthy digestive system. They were consuming more than enough copper to sustain their nerves and blood. The problem, therefore, was not a lack of supply in the food, but a failure at the invisible border where food enters the body. To understand how this failure occurred, we must look at the inner lining of the small intestine. This lining is not smooth. It is folded into millions of tiny, microscopic ridges, creating a vast surface area designed to catch nutrients. These ridges are covered in a single, continuous layer of specialized border cells. Every drop of water, every vitamin, and every mineral must pass through these border cells to gain entry into the bloodstream. Because their job is so demanding, these border cells have a very short lifespan. They exist for only a few days, absorbing what they can before they naturally detach from the intestinal wall, drift away, and are replaced by fresh cells from below. Inside these transient border cells is a fascinating regulatory system. Heavy metals like copper and zinc are vital for our biological machines. But if free-floating metals accumulate too quickly in the blood, they become highly toxic. To safely manage the flow of these elements, the border cells produce a specific storage protein. You can imagine this protein as a molecular sponge designed to catch and hold onto heavy metals as they pass through the cell. Normally, these molecular sponges hold a small, safe reserve of metals, gently releasing them into the bloodstream through the back of the border cell, exactly as the body needs them. It is a perfectly balanced system of supply and demand. However, the body monitors its zinc levels with particular caution. If the border cells detect an unusually large influx of zinc arriving from the stomach, the system initiates a defensive response. To prevent a toxic flood of zinc from entering the blood, the border cells begin manufacturing thousands of extra molecular sponges, attempting to soak up the excess before it can cross the threshold. Following the biological breadcrumbs of this pathway, the neurologist ordered one more test, this time checking the patient's blood for zinc. The results were staggering. The patient's zinc levels were astronomically high, reaching concentrations that were deeply abnormal and impossible to achieve through diet alone. With this final piece of data, the beautiful, intricate machinery of the patient's failing body came into perfect focus. The massive, unexplained flood of zinc had triggered the intestinal border cells to overreact, filling themselves with an armada of molecular sponges. But this defense mechanism has a fatal chemical flaw. While the production of the sponge is triggered by zinc, the chemical shape of the sponge actually prefers copper. Its magnetic attraction to copper is far stronger than its attraction to zinc. If one of these sponges is holding a molecule of zinc and a molecule of copper drifts by, it will eagerly drop the zinc to bind tightly to the copper instead. Inside the patient's digestive tract, the border cells were overflowing with these sponges. Every time the patient ate a meal containing healthy, necessary amounts of copper, the sponges immediately snapped it up. The copper became securely trapped inside the border cells. Because the sponges refused to let go, the copper was never allowed to cross the final threshold into the bloodstream. It sat there, locked away just millimeters from where it was desperately needed. A few days later, as is the natural life cycle of the intestinal lining, those border cells reached the end of their brief existence. They gently released their grip on the intestinal wall and were swept away through the digestive tract, carrying all the tightly bound, precious copper completely out of the body. This microscopic theft occurred millions of times a day, week after week, month after month. The patient was eating plenty of copper, but absorbing absolutely none. The massive excess of zinc had hijacked the gates, forcing the body to methodically discard a crucial element. Deprived of its supply, the bone marrow faltered, producing swollen red cells and frail white cells. Up in the spinal cord, the cellular maintenance crew ran out of materials, and the vital insulation around the nerves simply melted away, slowly disconnecting the brain from the legs. The neurologist had successfully charted the mechanism of the paralysis. It was a profound chemical imbalance, a starvation orchestrated by a biological defense system working exactly as it was designed to, only in the wrong circumstances. Yet, as the medical mystery resolved into clarity, the human mystery only deepened. The patient was saturated with an amount of zinc so immense it defied logic. It was not coming from industrial exposure, and it was not coming from their diet. The investigation had reached the limits of what a microscope and a blood test could reveal. To find the source of the metal that was quietly paralyzing the patient, the doctor would have to look closely at the mundane, everyday habits of the person sitting in the examination room. The physician sat down with the patient, setting aside the thick folder of complex laboratory reports to focus entirely on the rhythm of a normal day. They needed to map out the physical environment of the patient's life. Together, they went through everything, moving thoughtfully through each room of the house. They discussed the types of cookware used to prepare meals, searching for old, unlined pots. They reviewed every bottle of vitamins and supplements sitting on the kitchen counter, and they even talked about the age and materials of the plumbing in the patient's home. None of it pointed to an influx of zinc. The conversation gently drifted toward eating habits and dental care. It was then that the patient mentioned a minor, persistent frustration they had simply learned to live with. They had been wearing poorly fitting upper and lower dentures for years. Because replacing them was expensive and required multiple visits to a dentist, the patient had adapted. To keep the loose dental plates from slipping while talking or eating, they relied on a common, over-the-counter denture adhesive paste. When a normal application did not hold the plates firmly enough, the patient simply squeezed out a bit more. Over time, as the gums changed shape and the fit worsened, applying the paste had become a constant, daily routine. It had escalated to the point where the patient was going through several large tubes of adhesive every single week. The doctor listened carefully, noting the sheer volume of the product being used. A quick review of the adhesive's ingredients provided a very quiet answer to a very loud physiological problem. Many common denture adhesives of that era relied on zinc as a primary stabilizing agent, using the metal's properties to help the paste grip the moist tissues of the gums. Used sparingly and precisely as intended, the microscopic amount of metal posed no danger. However, the patient was applying thick layers of the paste multiple times a day. As the adhesive naturally broke down, mixing with saliva during hours of chewing and talking, the patient was constantly, unknowingly swallowing small amounts of it. Over several years, this relentless ingestion amounted to a massive dose of zinc, a heavy metal burden far exceeding what any human digestive tract was meant to process. The condition finally had a complete name: zinc-induced copper deficiency myelopathy. The word myelopathy simply refers to a disorder or injury of the spinal cord. In this specific case, the chronic swallowing of a zinc-heavy dental paste had forced the intestine to block the absorption of copper from food. This slow starvation deprived the spinal cord of the essential elements it needed to maintain its electrical insulation. The symptoms that had once so closely mimicked an untreatable, degenerative neurological disease were entirely driven by the quiet chemistry of a mundane household product. With the root cause finally identified, the treatment was remarkably straightforward. It did not require advanced surgical procedures or experimental medications. The first and most important step was simply stopping the harm. The patient discarded the zinc-based denture paste, replacing it with a temporary zinc-free alternative, and eventually underwent the dental work necessary to fit new, secure dentures. To repair the profound deficit in the body, the doctors prescribed copper supplements. Initially, the patient received these replacements through a slow intravenous drip, bypassing the digestive tract entirely. This ensured the vital nutrient reached the bone marrow and spinal cord as quickly as possible, without having to navigate the lingering roadblocks in the stomach. As the zinc levels in the blood slowly drifted back down to a normal, healthy range, the digestive gates opened again, and the patient smoothly transitioned to taking a simple, daily oral copper pill. The body's response was a steady return to balance. Within just a few weeks, the bone marrow resumed its normal work. The red blood cells returned to their proper size and number, lifting the deep, heavy fatigue that had burdened the patient for so many months. The white blood cell counts recovered, restoring the immune system's gentle watch over the body. Healing the nerve damage in the spinal cord was a slower, more delicate journey. The thick insulation that had worn away from the long nerve tracts could not be entirely rebuilt, meaning the patient retained a subtle, lingering numbness in their toes and feet. However, the steady progression of the paralysis stopped completely. Over several months of calm, persistent physical therapy, the patient regained enough strength and coordination to leave their walking aids behind, moving independently once again. In the end, this case demonstrates that the most profound diagnostic breakthroughs often occur far away from the glare of advanced imaging machines or complex laboratory sequencing. The truth of a disease is frequently woven into the ordinary, overlooked habits of daily life, waiting for a clinician patient enough to sit and listen to the whole story. It serves as a lasting reminder that healing requires looking past the microscopic pathways to genuinely see the person navigating the world. Medical mysteries are rarely unraveled by sudden epiphanies, but rather by the slow, careful accumulation of seemingly insignificant details. The rest of the details can wait until morning. Good night.